Welcome everyone today to our fifth Project Echo session, highlighting subject matter experts and topics relevant to Region 8 disaster preparedness. Today we'll be hearing from Annette Newman on applying burn ICU expertise to large-scale emergency preparedness. Before we begin, I'd like to just take a moment to orient any of our new attendees to the Project Echo platform. This platform aims to support case-based virtual learning that connects experts to public health officials, responders, and clinicians working in the field. This learning series was awarded to Denver Health by the Robert Wood Johnson Foundation via the Echo Institute, and will be holding sessions twice a month through September 2026 on topics critical to disaster preparedness. We hope to reach our Region 8 audience in Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming to strengthen preparedness and response through shared learning. We encourage on these sessions any open discussion or comments you may have. So please feel free to raise your hands, come off mute, or put any of your questions or anecdotes in the chat. And then just some brief disclosures before we begin. This grant is funded through the Administration for Strategic Preparedness and Response. The content is produced by the individual presenters and does not represent the official policy of the U.S. government. Additionally, this information is not meant to substitute for professional medical advice, diagnosis, or treatment. All right, and with that said, I'd like to introduce today's presenter. Annette Newman is a disaster preparedness consultant with the Utah Hospital Association, the Western Region Burn Disaster Coordinator for the ABA, and the Utah State Coordinator for the Western Regional Alliance for the Pediatric Emergency Management. She comes to us today with over 35 years of experience in burn intensive care, as well as coordination of burn disaster response across a 13-state region, working closely with EMS, hospitals, public health, and federal organizations. Thank you for speaking with us today, Annette, and I'll pass it over to you to begin.
Thanks, Katie. Well, I'm excited to see some familiar names and some familiar faces. And if you will just humor me before we start, because depending on kind of the audience that we'll have, I'll adjust some of the content to wherever you're from. But put your hands up as either pop off camera and raise your rail hand, or raise your, like your virtual hand if your screen stays black. But hands up those that are EMS on today. So no EMS. Hands up anyone from the hospital side.
Sorry, I couldn't figure out the hand thing. I'm EMS.
Okay. No judging, Jason. How about hospital side? Sweet. So some hospital. How about public health? Great. Sweet. Is there anyone that I've missed? And if there is, do you want to come off mute and let me know?
I'm a physical therapist.
Sweet. Cool. Now, is that you, Lindsay?
It's Megan.
Megan. I'll try and throw some physical therapy stuff in there. So it's, I'll actually write it on a sticky note. And then there's probably a couple of spaces where I can insert some PT specific stuff. So, well, I am excited that you are joining and wanting to know a little bit more about this topic. Deb, I am so glad you're on too. We're on a couple of other meetings as well, and so it's great to see your face, and then always good to see you, Steve. Let me share my screen. All right. Are you seeing something? All right. Perfect. You already have the title, so I will move on to the next data slide, because I'm kind of a data geek. And so what I wanted to do was throw some food for thought in right up front. I mean, my passion is obviously fire, but I also work in other response fields as well. But I'm throwing the fire in just because it's almost 60 degrees in Utah. We've had 2 snowstorms this year, and wildfire is top of my mind for what will be going on starting spring and then all through summer. It is super frightening, actually, because we've all been so warm here. But 85% of wildfires are human caused, and I don't think humans are going anywhere. And I think, as we've seen, especially since the LA fires, this has kind of been brought to the forefront, but there has been an increase in arson that we're noticing, some actually caused by firefighters, others by other people. But that increase in arson peak is really of interest and can really impact that wildland fire potential. The other thing, and I'm not going to read everything on screen, but the other thing that's really important to notice is the number of people that have been evacuated in the last couple of years. So greater than 216,000 in 2025, and in just two California wildfires, greater than 50,000. So we're looking at this explosive potential for our upcoming summer, and we're looking at big evacuations. So that impacts all kinds of different systems, right? So this scale can stress even those that are well resourced. I love this quote. It's one of my favorites because we all have plans. It's how we use them, right? And in burn disasters specifically, usually it comes with a lot of smoke, a lot of chaos, and typically it occurs between the hours of midnight and 2 a.m. And we'll go through a couple of case studies and you'll see that's where I'm pulling that data from. And we all know that relationships are what really matters. And it seems that multiple folks that I talk to have said it'll never happen here, and that isn't really a plan, and I'll show you kind of in one of these case scenarios what that might look like. We do have some objectives today. Again, I'm not going to read all the way through them, but hopefully by the end you'll be able to describe some key operational challenges that have been noticed in some recent disasters. I don't need to tell you because you're in Region 8, but you know the limited burn center capacity and our rural geography across Region 8 states. And then hopefully we'll identify some practical strategies and some actionable steps that we can take to help us all to lean into readiness and work as a team. So let's talk a little bit about that, our first case study, which is the Aliamanu fireworks incident. Do any of you, like, show of hands up on Hollywood Squares? Are any of you familiar with this? Let me talk you through the story. So it is New Year's Eve going into New Year's Day. This is 2025. And Hawaii has a huge historical firework tradition. And so at midnight, there were some homes in a neighborhood in suburbia. So kind of like my streets or your streets, right? Just regular suburban neighborhood. And there were some fireworks, a lot of fireworks, a lot of illegal fireworks. So those firework cakes that you get. And one of them fell into the garage and ignited all the fireworks. So if you can think of this house in suburbia with lots and lots of folks celebrating the incoming New Year, so parents, children, all kinds of folks just kind of sat there about to watch this big aerial firework display. And when that cake firework fell into the garage, it ignited all of them and they all shot into the crowd. And so now you've got these basically missiles coming into this large gathering of people that were with children and sat in chairs. And so when they started firing into this crowd and hitting people, then people started running and then started getting hit. And so there's this super chaotic scene. There was an initial call went out from those that were there, and the first EMS arrived on scene really, really quickly. So this happened at midnight. And so you can see the first EMS were on scene at 7 minutes after. So I think it was Jason was our EMS guy. And there were 22 patients identified on scene. This was basically kind of battlefield, if you will, because these are, for all accounts, missiles that are fired into the crowd. And you can imagine, because there was this really dense number of people parked, There were lots of vehicles, so the EMS was unable to access it really easily. The access was blocked. And then everybody came out of their houses. So the streets are packed. There's this chaotic scene, and the EMS requested police support. And in this incident, they did something that I have never heard done before. Perhaps it has been done before. And Jason, please speak up if you know of it. But the officers went into the scene and they actually used active shooter response tactics to reach the patients. And then because the scene was so chaotic and so crowded, they carried the patients on sheets to a rally point several blocks away. So the officers went in, they ran with the patients to the EMS, which were staged at an intersection a couple of blocks away. So there was a significant distance between the scene and the rally point. So pretty horrific operational challenges. And so this impact to the system, you can imagine. So at the time, the burn center, the only burn center there, only has 4 beds, so very, very small capacity. So local hospitals and the burn center reached capacity very, very quickly. And as you know, with all scenes, so whether it be a BMCI or whether it be just a regular MCI, that scene was cleared in an hour or less. So they did a pretty incredible job. And then, as with all MCIs, the patients were stabilized and the patients were distributed according to the protocols within that area. And then secondary transfers occurred after that. But there was a really key operational lesson learned in this incident, and it's learned in all burn incidents, and that is that non-burn facilities rely on burn centers, and non-burn facilities become burn facility surge. So that's really important as we think about the education and training that goes into that. And so that needs to extend beyond the burn centers. So let's look at something that is pretty important. So first, incident overview, we had 4 scene fatalities, 20 plus patient injuries that had to be transferred, many with blast and burn injuries, really, really severe. And so what this was classed as, and for those that are unfamiliar with ABA classification, so American Burn Association classification, this was a type 2 to 3 classification. So it exceeded the healthcare system and it exceeded the burn care system. So this is a small area with small amount of burn beds. And so it exceeded both the burn care and the healthcare system. And so it was huge impact. This was an incident that had DISCA, or Defense Support of Civil Authorities. So the governor requested assistance from the DoD. So it was not an NDMS activation, but there did end up being 6 patients moved to Arizona. And we'll talk a little bit about that, and we'll go back to this type 2 classification as we kind of go back and forth through similarities of Region 8 to this incident also. So let's look at it a little bit for those of you that are saying, well, why does this apply to me? This is Hawaii. This is, not Region 8, and we're mainland. So what is the big deal? Well, the big deal is that the trauma system within Hawaii kind of looks a lot like some of our states, right? So we do have a burn center, but it's a very small capability. And I'll show you a slide of Region 8 upcoming. And you can see that there are 7 level 3s that are there, and a level 1 and a level 2, but some of our states don't even have that. So there were a lot of level 3s that actually received really critical patients, because kudos to the EMS, they did what they do all the time, and that was distribute the patients to facilities, any facilities that could take them, so they only had 2s and 3s instead of 10 at one facility. But what's really important is that the level 3s and unders, they got patients from this incident, and then the transfer happened into the mainland from there. And if we look at our burn capacity in Region 8, you can see that only 2 of 6 states have burn centers. So Colorado has 3, Utah has 1, but there are no other burn centers within the other states. That doesn't mean that folks can't take care of burn patients, can't and they should take care of burn patients, right? Because sometimes we know that because of our geography, patients can't be moved. So I know that sometimes I'm from Utah, and so sometimes we would see patients that were 8 and 10 hours after their injury. What's really important is they can be cared for via distance, and we're not always going to be able to move them because of weather. So our rural geography really sets up Region 8 for a couple of nuances that are not typically seen, in that our transport times are pretty large already, and often those patients require interstate transport. So we're familiar with each other. We have this hub spoke network, but we don't have very much capability. And as you can see in that key message right there, burn disasters quickly exceed the capacity of burn centers to manage patients. And I'll tell you another story about Arizona. You know, Arizona got all these patients from Hawaii, and we'll talk a little bit more about that in a minute, but they're also managing local burns within their state, right? So it's not like they get all of these patients from somewhere else, and then the intake stops. It's like any disaster. There's still house fires. There's still other things that need to be taken care of, and large amounts of patients can be incoming also. So let's flip back to Hawaii, and let's take a look at this burn mass casualty incident to one of the non-burn centers. And let's take a look at Queens. And we're going to be comparing some lessons learned by Queens in the following slides. But again, I'm not going to read all of this to you. You can see the horrifying picture that is on the screen, right? These guys had 16 trauma activations in 80 minutes, and 42 trauma patients arrived in that midnight to 07 hour block. And they're not just getting the patients from this burn mass casualty incident, they're getting patients from all around their surrounding area too. So pretty severe impact. You can see that 7 of those activations were red. And again, this doesn't just count this only accounts for those patients that went to Queens. It doesn't account for those that went to their lower level hospitals. But you could see they did get a significant amount and were super busy. I had the opportunity to work with some of the physicians from Queens on this, and they did an absolutely tremendous job. So let us flip back again to what we talked about earlier on. So this was a type 3 BMCI classification, right? So impact to both healthcare and burn care systems. So let's look at some of the capabilities that we have within our region. We'll regionalize it. And what is hard is that the burn regions don't cross over to the FEMA regions. So you can see the burn regions up on screen, but the FEMA regions look a little bit different. So for those of you that aren't aware, there are 5 United States burn disaster regions that fall under the umbrella of the American Burn Association, and there's actually 1 Canadian region, and Canada is huge, right? Is the size of the US pretty much. And then for our regional example, this matters because if there is a burn disaster within Region 8, then we know that we have some capability. So we have about 469 beds in the West. And again, things are a little different. The Dakotas are actually in the Midwest region, although there's hub spokes out from there, so they would deal with who their regular hub is. But you can see, I just jumped on the watchboard this morning, and I'll talk a little bit about the watchboard in a minute, but there are 62 immediately available burn beds as of now, and 226 surge beds. So that means that given, 6 or 12 hours, the burn units can push out patients and intake large amounts. So we know that our capability within that huge blue area in the West is around 250. So if there's a big burn disaster that is over 250 patients that need a burn bed, then we would have exceeded our regional capacity. And we use something called the Nevada Watchboard. It's a burn watchboard, and I will show you what that looks like. I don't work for them. I'm not pushing any product. But what it does do is it helps to augment whatever mocks you have within your own states. Or even, as I think of you, Jason, for EMS, it allows you to visualize where those burn beds are if you need to visualize that. So each of the burn regions has a coordinator. I'm coordinator for the West. And what we're tasked to do is to activate and respond to a disaster. I mean, just like last night, I was sat reading, and we got I got pinged for a shooter incident that happened in our state. So it's like the burn coordinators can be wherever they're at, and then they get pinged, and then they spool up, and then they stand down according to whatever is going on. But one of the things that we're tasked to do is to provide situational awareness to people like you in the West, and to support you. We don't take over your role. We're like, hey, here is some information that perhaps that you could use. So it augments whatever it is, whatever systems you're using, and it's not limited by typical geographic boundaries, right? So we don't stop at just Region 8. We actually cover the entire West. So we have a visualization on all of those beds. And that's really important. And it's important because the watchboard, this is the watchboard on screen right here. You can monitor this, right? And one of the end slides is how to get access. Access is free. You don't have to give your firstborn or anything. And you can go in, and there's a couple of other cool things that can enable you to respond to not only burn MCIs, but to other MCIs also. But you can have a regional view of where beds are, and those are adult and pediatric. But it can be utilized in your mocks or to make decisions when you're boots on the ground and maybe even having to distribute patients. So how did that interplay with the Hawaii incident? Well, you can see on the screen right here, right up in top, you can see Queens had 12 patients that they took in total. Straub took in 8. Straub is the local burn center. But you can see we were activated. I was activated at 12:12 on New Year's Day. So that was at Mountain Standard Time. So activated a little bit late. We would have liked that heads up probably a little earlier, but that's when it came in. And then within 15 minutes, we were able to send resources to the hospitals to help them take care of burns. But those resources never ended up to the boots on the ground. After we did our AAR, we found that out, even though they had been pushed out. You can see that there were plenty of beds that were available, but Hawaii is geographically away from everybody else. So kind of like our states in the West, right? But you can see by a few hours later, we were able to identify the beds that patients could be moved to from Hawaii to the mainland. And there needed to be one center, because this was not an NDMS activation, but again, it was what's called a DISCA. And so those patients were all going to be put on a DoD plane and flown to one location. So think of that, for those of you in public health, kind of like an FCC, really. And the FCC did get involved in Arizona. So those patients all were taken to Arizona because that was the only burn center identified that could take 6 critical patients, and that had been approved by their C-suite. And that C-suite involvement is really important as you think about patients coming in from a non-hub spoke area. So we have agreements with the people that we normally do hub spoke with. But sometimes if those patients are coming from an area that is not typical, then that needs to go up the chain of command, because ultimately there's a pay source, right? And so Arizona was where those patients were going to be moved. And I want you to look at the top, which is really important, and it interplays with kind of the next scenario that we'll talk about. And it's that those centers took care of patients for 4 days. Those patients weren't moved until the 5th. And so that's really important as we think about geography within, FEMA Region 8, because perhaps you may be asked for whatever reason to hold on to patients you wouldn't typically care for a long period of time. So I think about those level 3 hospitals that took in really critical patients. Those hospitals kept those patients for a significant amount of time until they were able to get that secondary movement. So that timeline is really important. Here's an example of the push pack that was sent out. So you can QR that, and I'm happy to share all of these resources with Katie, and some of you may already know about them. Deb, I know you know about them because you helped put this together. But those were all pushed out, and they have some of the resources that we'll see in a minute. So let's go back again to the watchboard, and I want to show you a couple of things if you're in the watchboard that might be super helpful, and that may also be maybe new information to you around burn MCI specifically. So on the watchboard, there's what's called an information center in one of the top tabs, and the information center has the AARs. So we do AARs after each burn activation, so you can go in and read comprehensive HC AARs in that area. There's also a document that talks about burn center contacts. And also has the document that you just saw, the resource push pack, so that you can download it and click links and send it to whoever needs to be ready. But that information center houses those documents that look at Region 8, the FEMA region, and look at the burn region. So there's a map with click links that you can click on the regional contact for those areas. So that I'm thinking about, South Dakota and North Dakota specifically, if there is anyone from those states, but you can see your contact in the Midwest, because that would be ABA region Midwest versus FEMA region 8 for the burn world too. The other thing that I want to put your attention on is the factions tab right at the very top. And factions allow folks to be able to push out mass notifications. And those people don't necessarily have to be on the watchboard. You can add email addresses. So this is something that's pretty new. Factions isn't new, but the concept of being able to push out mass notifications to people that are not on the watchboard is new and just getting worked on currently. And so let's just say, Jason, you were looking at the watchboard and you're like, hey, this is where the burn beds are, but you wanted to add your battalion chiefs and your incident command. Then you can blurb all of that out and add their emails to that faction push out. So it can be specific to an incident. And this was used for the Formula One races in Vegas. So this has been tested actually multiple times, but because Vegas always has a lot going on, then all of the things that you're seeing here have been tested. And then the other thing that I want to draw your attention to in that lower area is the green, yellow, red. And this is really important so that we're all speaking the same language. There is an assigned color, an assigned patient criticality, if you will, assigned to that color. So let's kind of go here so you can see it a little bit better, but in that top right-hand corner, so the burn world has standardized their patient definitions based on colors. So this interplayed because I don't know, maybe a decade ago we did an exercise, and even burn folks can't all agree on criticality, right? And so what we wanted to do was put a criteria with a color. And this standardized language is really helpful. So Jason, if you got on the phone to me and you said, hey, we have 5 reds, then I know what you're talking about. Oh, you got on the phone to your local burn center and you said we have 5 reds. Then that red matches certain resources, right? So a red would be a patient that needed a ventilator and perhaps needed to go into the ICU. And those categories in the burn world are important because people don't really talk about it like that. We have start and we have jump start, but and this criteria kind of matches those. So in Start and Jumpstart, a red patient would be somebody that was critical, and a green patient would typically be your walk-in wounded. In the burn world, that would be a burn under 10%, which again may or may not even be admitted. So having that standardized language means that communication is optimized. And that also means that education can be done on blue sky days, right? So not just dark skies. I mean, hopefully things would be done on blue sky too. The other thing that it does is it also mirrors that crisis, contingency, and conventional mode. So if you see on screen right there on the watchboard, you see the green dots by, this is the West region, but you can see the entire US if you jump on the watchboard, and Canada. But during Hurricane Helene or during the IV shortage, centers would flag a different color. So those that were running short of IV fluids would flag yellow, so they were in contingency mode. And so if everybody could see, it was very visible that there was a scarce resource and a shortage, and so that those colors can change. And that is identifiable to those folks that are on the watchboard, which is really crucial if you're looking for folks that need to intake patients, because the question then to ask is, do they have the resources to be able to do that, or should somebody else do that? And these are some of the resources, again, that can be utilized both in blue sky and dark sky that are on the watchboard. One of the things that is super helpful is that little kind of buddy badge that you can put on your pull tag, or there's posters on there. And these match evidence-based standards, right? So they align with advanced birth life support, and they align with best practice. So let's flip back to Hawaii again before we jump to another MCI. And so what were the lessons learned? So for those of you that are from hospital systems, what is it that you need to do to prepare your EDs? So one of the things that was really important in the Hawaii firework BMCI was to utilize normal workflows, to not deviate from those standards of care that they do every day. They found obviously communication is always problematic, so accurate communication. But there are sometimes incidents where people are on social media and the communication that is coming in is not accurate. So ensuring that there is an accurate communication channel set up with accurate data is really important. The Hawaii folks also did something that was pretty amazing, and they pulled down their inpatient teams to their emergency department, and they were the ones that then took the patients that needed to go to the ICU, looked after them in the ED, and then took them up to the ICU with them, which really allowed the emergency department to function at maximum capacity, because the ICU nurses stayed in the ED until the patient was transferred, received the patients, and then they were able to take them upstairs. And the other thing that happens a lot is when we think about doing exercises, a lot of our exercises are during the day. And so this was a night shift on that hadn't been to a drill. So when we think about, our training and our exercises to ensure that those drills occur at night too, so that the staff are familiar with what would go on in a patient surge. And then this is a big one, and we'll hit on this in a second too, but burn victims, they really traumatize caregivers. And so to ensure that any of the staff, so non-burn facilities plus burn facilities, have help. And this was a big one, Jason, for EMS and police too. Just these events they're not typical, and so when there's a big event like this, to ensure that there's ongoing support as folks that receive these patients are first responders, first receivers, they're pretty traumatized. So let's look again at some more. This is a super busy slide. I'm not going to go through it all for sure, but there were some really important lessons learned here. And that was a recommendation for adding provider education and just-in-time training resources for those non-burn facilities. The burn facilities don't need those resources, but provider education for facilities at non-burn facilities did. And then to ensure that relationships are established with the burn communities and burn consortiums. And then because this also, was a liaison with the military, there was some pathway confusion, right? We each have our lanes. And when people are unfamiliar with lanes, then they tend to cross a little bit, and that leads to communication issues. So to understand the pathways to request access for military resources, if that's something that is required. Alaska works on this a lot because they're really close to their military, but to understand this for augmentation is important. And then obviously supply chains and relationships with sister hospitals as we continue to navigate these challenges that this new world kind of brings us, right? And this new shortage and agreements with each other is really important. Relationships. So I love this quote. Always just kind of makes my heart skip a beat just a little bit, but it's taken from Alice's Adventures in Wonderland. And it always reminds me that unless we write down those lessons, then they're lessons observed versus lessons learned. So we have to continue that through and make sure we actually do something about what we've observed. And one of the things that has come out in multiple, especially burn disasters, both Lahaina and Aliamanu, and others, is the need for mental health resources. Burn injuries and traumas like this, like the blast kind of injury, they're pretty graphic. So, and they don't happen very often, and they cause emotional overload to those folks that are working them. There's often no time to debrief. These folks were extremely busy. Just like another incident we're going to talk about in a little bit. And they cause psychological trauma. So to make sure that there's not only that short-term phased intervention, but there's that medium and that long-term intervention, those phases that are needed for those teams to just double check on them and make sure that they don't have that caregiver fatigue and that high emotional toll that these kind of incidents can cause. So let's flip it again to a recent incident. Hands up anyone that read about the Crans-Montana, so the Swedish burn incident. Anyone aware of that? This is something that just happened. So Katie, I see your hand. Steve, I see yours. And Jason, I see yours too. So this is something that happened this year. So we've got the Aliamanu fireworks incident, right? And now we've got the Swedish incident. So fireworks, common theme, right? As we think about celebrations. So again, this incident happened on New Year's Day at a bar. Massive casualties, right? So 41 deaths in this one. Remember, there were 4 scene deaths in the Aliamanu, and that's because this one was inside. So there's a big difference between a confined space and fire and an outside space and not confined, and that's the smoke inhalation and the deaths that occur from smoke inhalation. But this one had 41 deaths and 116 people injured. So much bigger than the Aliamanu injury. And this was caused by sparklers attached to a champagne bottle that ignited the ceiling. So there's decorations for New Year, and then there's acoustic foam, and this should trigger some memories from other events for those that even haven't heard of this incident. And there were multiple patients that needed to be moved. So again, we've got a burn disaster with trauma, right? That because there is some crushing injuries in addition, and smoke inhalation, etc. So the early report said there was 38 to 44 patients that needed to be moved out of country. So again, likening this to Aliamanu There were multiple countries involved, so France, Italy, Germany, and Belgium that came in, and they had teams that came in and looked at the patients prior to moving them out to assist the Swiss hospitals, and then those patients were moved out. And they were moved out in 2 days. So remember, the patients in Aliamanu were there for 4 days. These patients were moved out to different countries within 2 days. So again, that movement of patients is really across normal boundaries is really important. And when I looked this up on as of the 5th, there were 12 patients still hospitalized from this incident because burn patients stay a long time, right? I've looked after patients that have stayed 8 months in the burn unit. So we're looking at long periods of time. So what's notable for us is this was another ignition. It was rapid burn surge, patient distribution, and then that coordination equals clinical care. So where should these patients be moved? And where would that space be that can provide optimal clinical care, right? Is what we're really looking at. And if we kind of look at a theme here, we're seeing this recurring pattern of burn mass casualty incidents. So we had the Aliamanu incident, we've got Crans, Montana, a couple of others that I threw on there, but specific for us in the US would be the Station nightclub fire, the Kiss nightclub fire, again, pyrotechnics. And so, as I think about some of the things that are happening in our state, right? We just had a big incident happen at Saltaire, which is where a lot of raves occur. So, but as we think about concerts in our local area and the pyrotechnics that are often go along with that, are we spooling up as hospitals? Are we spooling up as EMS? Are we spooling up as public health? And do we know when those incidents are? And are we thinking about potential surges, especially if there's pyrotechnics? Are we even asking those questions when a venue comes in a town? And so that we can be on alert for the kind of injuries that those incidents cause. So again, patient movement is care. So those clinical decisions are really important when we think about placement. And one thing that interplays with that, so as we look at that timeline of patients, burn patients, the first 24 hours are really critical because we're resuscitating those patients. And especially if trauma is involved, now you've got your trauma resuscitation and you've got your burn resuscitation. And so ensuring that there's a communication between non-burn centers and burn centers is really important. And some of that is, the capability to get on a phone, to text your friend, or to utilize telemedicine to ensure that optimal care is occurring so that patients aren't overloaded in that first 24 hours, which is the most typical thing for us to see for patients. So one of the things that I thought was particularly important before we jump to another case is we often overinvest in the likely and underinvest in the catastrophic, right? So like nobody on there had a big burn MCI on their radar, right? Like especially with fireworks. So to ensure that we're giving thought to all of these things as opposed to the probability versus perceived risk. So let's flip a little bit and let's go to the LA fires. Again, this is something that wakes me up at 2 o'clock in the morning. We've got a lot of dry going on where there's tinder boxes all over the place. I think about, the recent fires in multiple different areas that can cause flooding as we think about the whole fire landscape. It's not just about a fire ravaging the area, it's about the floods and the landslides that occur afterwards. So let's move to the LA fires. So they were at the beginning of 2025. So 2025 started off the year with a big bang for sure. But California had multiple fires. And remember, some of those were arson set. There were some people charged. There were deaths in those. But one of the one of the fires actually triggered a potential evacuation need for one of the burn centers in California. And we were already activated and online and looking at burn beds, so exactly the same watchboard. So let's just say the incident occurs in Colorado, right? So looking at burn beds within not just Colorado, there's 3 burn centers in Colorado, but looking at Colorado's capability, looking at that in conjunction with other watchboards such as EM Resource or whatever it is that you use. Javari is one of the things that we use in Utah to look at bed space. But looking at availability of those beds. And then one of the things that we did during the LA fires, we triggered those factions so that everybody was in a loop. And then we started a text stream. So not only when the burn center needed to potentially evacuate, they were able to put how many patients they had, utilize that language of red, yellow, and green for their patient population. And then physicians and burn directors in other burn centers within California were able to look at the patients they had, the acuity they had with the color coding, and then say, hey, I can take 2 reds, I can take 1 green, I can take this. And that would be also something that would be feasible to do in Colorado too, really quickly using text streams and factions, and maybe some of this goes through your public health too. But the ability to do that is really important. And then also, if you think about, I was watching LA wildfires for multiple other reasons, but perhaps some of you, or perhaps you have families in LA and you're watching what was going on there. But also our FEMA colleagues watch it, ASPR, our coalitions, right? Fire dispatch centers and counties watch that too. So that's something that people can jump on and begin to look at those notifications and talk groups as they go up. But that's something that we were able to do during the LA fires that worked really well. So let's flip it a little bit as we kind of come to close. I love this slide. It was first pulled out in 2009, and as all of you recognize, we're constantly in deep contingency, right? So all our hospitals, it's rare that we're in that conventional mode. We're always at that crosshairs, whether it be for staff stuff or space, which is what the slide before this kind of triggered. So let's talk a little bit about staffing, whether it be for burn MCI or whether it be for trauma or whether it be for any MCI. This is the reality. And these are texts that we get all the time. Down for nurses, please call the unit if you can come in. I need a nurse right now. I'll take anyone for any amount of time, right? No one in cluster. So for those of you that are online, this is probably a really familiar problem. We don't have the staff. And so when something happens, whether it's burn or whether it's burn and trauma, then to be able to call in friends is really important. And along those lines, burn response is a team sport, right? We are not alone. So there's multiple folks on even this call right now that can assist, right? So now, for those of you that didn't know, there was a burn consortium. Hi, I'm Annette. Please ping me if you need help. I know that Colorado, so the RDHRS does some fantastic work, and then Colorado DHHS also too. And then we have our EMS colleagues online too. So there's all of these people that can augment response if we call them and if we have them on speed dial. And the key there being have them on speed dial, right? So to make sure we know our lanes, our chains, and that those assistance calls go out in the chains that they're supposed to, so we don't leave anyone out. For the hospital folks on here, I just threw some pictures in here of some of the stuff that we have to prepare for burn disaster specifically, but it's the same for BMC, for regular MCIs too. We had big carts. We had 3 big carts, 2 with supplies, 1 for inpatient, 1 for outpatient, or for a tent in the parking lot, and the other on the unit, so that the nurses could have what they needed in a patient surge, or this could be in the ED, right? I know it sounds funny to label the door open me first, but we had charge nurses that would go to every other draw but the one they were supposed to go to, and so they asked for us to help them know which draw they needed to go in first. But these, the draw slides open and there's clear instructions on what to do, how to set up teams, how to huddle, checklists, right? Checklists are really important if you're getting staff in that's unfamiliar. So if we think back to the Hawaii incident, the ED pulled staff from their ICUs to now staff their ED. So checklists are really important if you're going to utilize either staff from the float pool or staff from an ICU to assist, so that they understand their role. And here's some roll cards that we had too. Just you pulled a roll card depending on what role you were. And for our physical therapist on here, our physical therapists actually had a role in disaster response, and they were definitely utilized. But to have those readily available so that when something happens, staff know, oh, hey, I just go pull my card, I see what's happening, or a new nurse comes into the unit that's unfamiliar, I give this to the float nurse, or I give this to the float CNA, or I give this to the float person. Here's where our just-in-time resources are, etc. So that internal stuff is really important. And then an awareness of partner stuff is really important. So I don't know what resources Jason has, but I would imagine that he has some that he can share. And I also know that Deb has some fantastic resources too. So utilizing the resources to assist and knowing what they are is really important in an incident. And I know that Asper Tracy has got, I didn't go into it yet, but they are having a new place on their website that looks at scarce resources. So there'll be an area that folks can go in, and then they can start to say whether their resources are short or whether they have additional that they can share with people. So that's one of the things that Asper Tracy is now going to be doing to assist with this continual resource shortage. And then there's also a dash tool that can be used specific to MCIs, so that you can look at the supplies that you have for your hospital size and how much you will need to take care of a set amount of patients that may come to your center. So knowing all of your resources is important. Here's some resources from RAPM when the wildfires occurred in LA. We put together some resource sheets that were specific to wildfire that can be given to patients who are being discharged or families that are going back to an area that has been scarred with that wildfire, about kids not playing in the rubble, etc., because of all the toxins that they contain. So those are all thoughts to like sheets that can be used to hand out to patients that come through, even with minor injuries that are going to be going back to their home, which is now a rubble site. The other thing we think about is our space and systems. And if we think about what occurred during the Las Vegas shooting, which is actually where this watchboard stood up, and one of the lessons learned around that response. But we have just this incredible capability for patient movement within systems. So I was on the phone this morning to a huge system, but our hospitals are able to distribute patients really well, pull in staff from other hospitals. So look at dashboards which contain patients and bed availability in other sites. But we learned something really important in the Vegas shooting, and that was that even though Jason might do a fantastic job on patient distribution, the people that are going to arrive in private vehicle may all go to the same space, right? So for example, Sunrise received 199 patients and 124 in the first couple of hours, but they are a big conglomerate, right? So they have the resources of HCA to assist them and other hospitals within their area that they have MOUs with, and so they're able to get supplies and equipment. So that's space which extends beyond hospital walls, and the systems within which we function in, which includes coalitions and mutual aid. that is huge. So knowing your partners and having again them on speed dial is really important. And again, these are just some examples of dashboards. But as we look to enhancing our medical operations coordination cells, as we look to push out of hospitals to our partners in the community, which includes SNFs and LTACs and our home care partners, as we look to push out those less acutes to intake the more acutes, those are all things that we should be thinking about within our plans. The other thing that's really important that goes along with the theme of this session is that burn disasters are a system problem, right? So if we think about what happened in Aliamanu, if we think about what happened in Switzerland, when a burn disaster occurs, it's not just typically a burn disaster, right? It involves the entire system. And so ensuring that if you have burn plans, they're not standalone. If they are, they'll fail. That they align with your counties, your jurisdictions, your coalitions, your EMS, and your hospitals is really important. That alignment of plans and knowing where those lanes are is really important. And then also not forgetting our specialties, our pediatric partners, our rural partners, and how they integrate into that hub spoke when the hub may be full. And now there's a disaster in a spoke that needs to be moved. That's tough. Where do those patients go? So let's, as we come to close, look at real world takeaways. So after this session, right, what are you going to do? Well, I jump on the watchboard again. It's no charge. It is an outlook for not only the West but for the international. And so even though North Dakota, South Dakota falls within the Midwest, they can look at the Midwest. There's a watchboard for the Midwest with where those burn centers are and the number of patients they can take. There's a watchboard for the West. It's a drop down on the watchboard. If you need help navigating it, I'm happy to. And Chris, who runs the watchboard, is also happy to help. We do burn bed counts every single Tuesday. So, and the data doesn't change very much because burn patients stay in hospital for a long period of time. So tomorrow I push out a bed count using factions. All of the units kind of put their surge and their immediate bed availability onto that watchboard so you can see what's available within your area. And again, even if you're not in the burn world, if you're Deb in the DHHS world, then knowing that availability is really valuable. Please, those of you that are on the call, if you haven't got burn education or just-in-time training, again, I can pass all of our resources to Katie that can push them out, or they're all on the watchboard. So knowing where your resources are, and then ensuring that you have the ability to connect, whether that be utilizing telemedicine or whether that be phone calls to friends, but ensuring that if there is a surge, you are able to connect utilizing a subject matter expert to assist with the resuscitation of patients, whether they be burn, whether they be trauma, whether they be both. And then relationship building, of course, is really imperative to know all your partners and your swim lanes and chain of command. And so I guess in closing, thank you for listening. Thank you for being online. Appreciate all of you, and I know we're almost at close, and so but happy to take any questions. Was there any questions in chat, Debbie, Katie, or anyone have any questions?
All right. Well, with that said, thank you all for attending today. We've recorded today's session and it'll be available on YouTube. Thank you, Annette, for speaking with us. And just a reminder, if you weren't aware, we have our next Echo session scheduled for Thursday, March 19th. We're continuing the burn topic, but we'll be shifting to chemical burns. So hope to see you all there. Have a good week, everyone.